Hello everyone, myself Dr. Sindhu Priya. I am Associate Professor and Head of the Department working in Yenepoya Pharmacy College and Research Center. Today I am going to teach you about the pharmacology of oral anticoagulants. Let us begin now. So at the end of the session you should be able to define and classify oral anticoagulants, and you can be able to explain the mechanism of action of warfarin and able to describe the pharmacokinetics, adverse effects, contraindications, drug interactions and uses of warfarin. Why we need to study about anticoagulants? Where are they used and what is the purpose of importance of anticoagulants? So when there is a blood flow to the brain and there is a small clot formed within the blood vessels, so what happens during that time? There will be blockage of the blood supply to the brain, and which leads to reduced supply of nutrients and oxygen to the brain or a part of the brain, which leads to necrosis or ischemia. So the cells in a part of the brain will be damaged and they will become non-functional. So as you can see here, a part of the brain is damaged because of formation of blood clot within the blood vessels. So what happens? The neurons which are present in that area will become non-functional. The functions of those neurons will not work anymore. So it may lead to some of the symptoms such as paralysis. So we can see the hands movements and all, leg movements and all will be reduced, and the facial expression will change. The person cannot able to see properly or may not able to lift their hands, may not able to talk, may not able to walk. So all these are the symptoms of stroke, cerebral stroke. So in these situations the anticoagulants will be used. These anticoagulants will reduce the formation of blood clot within the blood vessels. So coming to the definition, anticoagulants, these are the drugs which are used to reduce the ability of the drug to clot, blood to clot, and they are classified based on the route of administration as parenteral anticoagulants and oral anticoagulants. So parenteral anticoagulants, they are subclassified into indirect thrombin inhibitors and direct thrombin inhibitors. So indirect thrombin inhibitors includes heparin. And coming to oral anticoagulants, so this is what we will be learning today. So they are again subclassified into coumarin derivatives, direct factor Xa inhibitors and oral direct thrombin inhibitors. And among these, the coumarin derivatives are more significant and used more nowadays, and warfarin is included among coumarin derivatives. So if we see about introduction to warfarin or coumarin derivatives, they are originally antagonists of vitamin K. What is the role of vitamin K in the blood coagulation? So if you remember, the blood coagulation cascade involves 14 blood clotting factors, and these clotting factors will activate one another to form a finally fibrin, and which will form together along with the platelets form the blood clot. So if this vitamin K is not present, so the blood clot will not be formed. And these warfarin and other coumarin derivatives, they are antagonists of vitamin K, and hence they reduces the plasma levels of functional blood clotting factors. And warfarin especially, it will reduce the total amount of vitamin K dependent coagulation factors by 30 to 50%. So 50% of the factors will be reduced, only 50% will be available for the blood clotting. If we see in detail mechanism of action of warfarin, so it starts with the vitamin K and hypofunctional clotting factors. Hypofunctional means they are presently not functional. So such as factor 2, factor 7, factor 9 and factor 10. So these 4 factors, hypofunctional factors, they lack carboxylic acid, hence they are called as descarboxy factors. And these descarboxy factors will be carboxylated in presence of gamma glutamyl carboxylase enzyme. So gamma glutamyl carboxylase enzyme will add COOH group to these factors in presence of carbon dioxide and oxygen to form functional clotting factors, that is 2, 7, 9 and 10. And you can see this is a factor 2 prothrombin. So it contains now 2 carboxylic groups when compared to hypofunctional factors which contains only one COOH group. And these factors will be carboxylated in presence of vitamin K. So that is in the reduced form. So reduced vitamin K will be converted into oxidized vitamin K, that is vitamin K epoxide, when these hypofunctional clotting factors are converted or activated into normal functional clotting factors. So vitamin K is an important factor or catalyst which is responsible for the activation of clotting factors. And once these factors are formed, they increase the calcium binding property and helps in coagulation. After formation of the clot, once again the vitamin K epoxide or oxidized form of vitamin K will be reduced in presence of NADH and the enzyme vitamin K reductase. Vitamin K reductase will reduce the oxidized form of vitamin K into reduced vitamin K, and warfarin will inhibit this vitamin K reductase enzyme. So the vitamin K epoxide will not be converted into reduced vitamin K, and if reduced vitamin K levels are decreased in the blood, and this hypofunctional clotting factors cannot be converted into functional clotting factors, and the level of functional clotting factors in the blood will be reduced. So this is the mechanism of action of warfarin. And the point to remember, warfarin has no activity on fully carboxylated coagulation factors. I'll repeat the mechanism once again here. The descarboxy factor 2, factor 7, factor 9 and factor 10, these are hypofunctional blood clotting factors which are present in the blood. They will be activated in presence of gamma glutamyl carboxylase enzyme and reduced vitamin K, carbon dioxide and oxygen to form factor 2, factor 7, factor 9 and factor 10. And reduced vitamin K will be oxidized to vitamin K epoxide in this process, and thus formed factors will involved in the clotting process and form the blood clot. And the vitamin K epoxide, which is an oxidized form, can be reduced in presence of vitamin K reductase and NADH, so to form reduced vitamin K, and warfarin will inhibit this vitamin K reductase enzyme, and thus how the reduced vitamin K levels will be reduced in the blood or decreased in the blood, and the whole process will be inhibited. Warfarin action. So warfarin as well as its congeners act as anticoagulants only in vivo when it is given into the organism directly and not in vitro. If we take the blood into the test tube and if we add warfarin, it will not show any anticoagulation action. Why? Because it is acting indirectly by inhibiting the activation of clotting factors, but it is not directly blocking the clotting factors. Hence, we should remember the warfarin can only be act in vivo but not in vitro. And the action of warfarin depends on the half-life of various clotting factors. So, such as factor 2 has 60 hours and factor 7 has 6 hours and factor 9 has 24 hours and factor 10 has 40 hours. So, based on the half-life of clotting factors, the warfarin action also depends. And the synthesis of clotting factors will be diminished within 2 to 4 hours of warfarin administration. But the anticoagulant action will develop slowly after 1 to 3 days. Why? As soon as we give warfarin, we cannot see immediate anticoagulant action in the human being. Why? Because there are already clotting factors present in the blood and their levels will not reduce immediately. So, warfarin only stops the synthesis of new clotting factors, but it will not stop it will not show any action on the clotting factors which are already present in the blood. Hence, there will be a delay in between the administration of the drug and anticoagulant action. So, if at all immediate anticoagulant action to be seen, the warfarin is not the preferred drug of choice. But because warfarin will show the anticoagulant action slowly after 1 to 3 days of drug administration. This has to be remembered while studying about warfarin. Coming to pharmacokinetics of warfarin. So, warfarin has to be given at a dose of 5 mg per day for 2 to 4 days, and the dose has to be tempered, like followed by 2 to 10 mg per day. And this warfarin is completely absorbed orally, as well as it can be absorbed in intravenous route as well as rectal route. And this warfarin is distributed throughout the body or throughout the blood by binding to plasma proteins, especially majorly albumin. So, this warfarin is having the high ability to bind to plasma proteins and travel throughout the body along with the albumin, and it is metabolized by cytochrome P450 enzymes such as CYP2C9 and CYP1A2 in the liver, and it will be excreted in the urine as well as in the stool. The half-life of warfarin is about 25 to 60 hours. So, that is, it may be from 1 to approximately 3 days. Adverse effects of warfarin. So, warfarin, if it is given for the longer period of time, or sometimes it may show bleeding, alopecia, that is hair fall, and it also shows dermatitis and diarrhea and contraindications. So, warfarin should not be given when a person is having the bleeding disorders. So, what happens here? The person is already having bleeding disorders and the blood clot formation is delayed, and if we are giving warfarin, what happens? Clotting will not occur, and because of hemorrhage there are chances of the person death. So, we have to avoid warfarin when we are giving to the bleeding disorder person, and we also should avoid warfarin in severe hypertensive patients, and this also causes threatened abortions. Hence, we should not give warfarin to the pregnant women, and it also should be avoided in the people who are having the piles as well as gastrointestinal ulcers, and we can also avoid warfarin to giving to the patient having subacute bacterial endocarditis and the persons who underwent ocular and neurosurgery, and to chronic alcoholics, cirrhosis and renal failure patients. And we should also avoid warfarin in whether if we are giving aspirin and other antiplatelet drugs. Coming to drug interactions. So, warfarin is having a wide range of drug interactions. So, before administering warfarin, we should keep in mind about these drugs. There are two types of drugs. Some drugs will increase the anticoagulant effect of warfarin, and some drugs will decrease the anticoagulant effect of warfarin. So, we will see about the drugs which increases the anticoagulant action. Antibiotics, newer cephalosporins and aspirins, these drugs will increase the anticoagulant action of warfarin, and some of the drugs which displaces the protein binding, so such as sulfonamides, phenytoin and probenecid. These drugs also will bind to the albumin where exactly the warfarin is binding. So, what happens is these two drugs will compete along with warfarin for the same binding site. So what happens? These drugs will replace the warfarin in the plasma albumin, and so warfarin will come out of the albumin, and free warfarin levels in the blood will increase. So what happens when there is a free warfarin level increased in the blood, so anticoagulant action also will be more. And the drugs inhibiting the metabolism, so such as chloramphenicol, cimetidine, tolbutamol and phenytoin. These drugs when given along with warfarin, so these drugs will inhibit the metabolism of warfarin. So the same cytochrome P450 enzymes will metabolize the warfarin along with these drugs. So what is happening? The enzyme production will be reduced, induction will be reduced. So what happens? Warfarin metabolism is reduced, and thus the level of warfarin is increased in the blood. So once again, anticoagulant action of warfarin is increased when warfarin is given along with chloramphenicol, cimetidine, tolbutamol and phenytoin. And when warfarin is given along with liquid paraffin, it reduces the vitamin K absorption. So that's how the anticoagulant action of warfarin will again increase. And there are other kind of drugs which decreases the anticoagulant effect of warfarin. They are barbiturates as well as oral contraceptive pills. So when these drugs they are given along with warfarin, the action of warfarin is reduced. So either we need to avoid these drugs when we are giving along with warfarin, or else the dosage adjustments has to be done. So please remember the drug interactions while prescribing the warfarin. And uses of anticoagulants and uses of warfarin. So where we can use the warfarin? Warfarin will be used in treatment of deep venous thrombosis, pulmonary embolism patients, myocardial infarction and unstable angina, along with atrial fibrillation and cerebrovascular diseases such as cerebral ischemia or stroke, and during vascular surgeries. In all these situations or indications, we can use the warfarin. Summary: warfarin is a oral anticoagulant, acts only in vivo, and the action will develop gradually but not immediately. It acts by inhibiting conversion of vitamin K epoxide to reduced vitamin K. So it blocks the synthesis of coagulation factors. Care should be taken while prescribing the warfarin, as it has more adverse effects, drug interactions and contraindications compared to heparin, which is a parenteral anticoagulant. These are my references, and thank you.